introduce a concept which is good to think about and implement in your own practice too. It's called blended PCI. The concept of blended PCI is to use your BVS, use your drug-eluting balloons, and if you can't, you have a very bad bifurcation which you don't want to take a chance, then go in for a DES. So aim of the whole talk is to give you a concept that you should reduce the metal load as much as possible, and that's the way forward. We have to reduce the metal load. So nothing to declare. So this is an acute myocardial infarction in a 55-year-old gentleman who came to me with acute ST elevation, RCA infarct. So this is how the RCA angiogram looked like. So the next few slides I'll just go through fast. You know, everybody knows about it, so I don't have to talk. This is the the new MERES bioresorbable scaffold that's available. And this is the markers. The importance is about the markers. I will tell you why I'm talking about this, because you should know that there is a distal balloon marker and there is a stent marker. So when the distal balloon marker comes in touch with the stent marker, the stents are overlapping, not this way, but they just touch at the edges. So unlike a DES where you overlap this way, in a BVS you overlap with the tips of the stent touching only. And how you achieve that is the balloon marker of the second stent goes into the stent marker of the first stent, and when they overlap, the actual stent position will be just touching each other. This concept should be understood, because that is what I am trying to demonstrate in this case. So this is where the balloon marker goes into and overlaps with the stent marker, and when it gets deployed, the stents just touch each other. They don't sort of overlap over each other. So they just touch each other, the tip. And Dr. Colombo has shown in various studies that 1 millimeter area without any stent won't make a difference in your outcome eventually. That's how it gets deployed. So this is a pre-PCI run of the patient. It's a right coronary OCT done with only saline. There is no element of contrast in this. So I can do any number of OCTs as per my liking. And this is the distal part of it. The whole vessel is mapped. And once the vessel is mapped, you take independent areas. This is the distal landing zone. It's quite a good landing zone that we have, but there is a diffuse plaque there. This is the mid area, which has been dilated gently to get the OCT catheter through. You can see thrombus there. And this is the proximal area, which is the distal landing zone, the proximal landing zone. And you can see that proximal to distal, there is a significant difference in the diameter of the vessel. So I got a distal area of 3.21, MLA of 2.43, proximal area of 5.91. These are areas, not diameters. The morphology of the RCA can be put up this way. The tightest segment was about 2.43 millimeters squared. That was in the middle. This is a distal landing zone, and this is the proximal landing zone. You take your dimensions. And eventually we came to a lesion length of 58.4 millimeters, which cannot be obviously covered with one stent, hence the initial talk about how to overlap these stents. So we have a long this thing, and what we decided was we will go in with a 3.75 distally and a 3 proximally. Now you see, the concept of while we are taking in a BVS is that the fastest way to take a BVS, if it is possible, very distal, is to take a guideliner. You don't dislodge the BVS en route. But you have to understand that even a 7 French guideliner can just about take a 3 BVS. Any BVS above 3 will not go into the guideliner. That also should be known. So this, I have deployed the distal part with the help of a guideliner. That is the distal segment. This is the JR catheter. This is the guideliner. This is the proximal marker. This is the distal marker. The BVS has been placed in position. And this is the how the BVS went in. And this is the deployment. Okay. Well, once deployed, we realized that the second BVS has to be deployed proximally, and it cannot be deployed through a guideliner. So I had no options but to leave the whole thing at this stage and change over to a AL this time. So I changed to an AL 7 French and did the proximal thing. You can see I'm deep engaged. so that the BVS itself has to traverse as minimum as possible into the bare artery and deep engaged, and those two markers are now overlapping in the way I told you that they should be made to overlap. So once they are overlapped, then it's not moving. Control L. Okay. So this is the post-PCI run of RCA. It's very, very, very important to take a post-PCI run when you're put in a BVS. I know it's a BVS is a little difficult subset in a patient who is an acute coronary syndrome because it requires a lot of post-dilatation. But you see, despite post-dilating with that balloon which they have given you, I have a lot of areas where there is area where the apposition is not good. Although malapposition is no longer apparently no longer a very significant topic, but it looks nice to have the stent struts opposed with each other. Now, this is the area where the middle is the area where the things malapposition is the mid segment where there's a so-called overlap. So how do you identify the mid segment? As the stent struts coming in, you'll suddenly find one small millimeter of area where the stent strut count has doubled. That is the area exactly where there is a overlap segment. You can see one area where it is crowded. I will show it to you better in this picture. That is a small area. You can see the number of stent struts have doubled here. That is where you have this thing. And you can see that the expansion is also not adequate. There is a little bit of malapposition also. So when you have the concept of deploying a BVS without a proper imaging, please don't do it. It doesn't work that way. You have to have imaging, ideally in OCT, at least in HD IVUS, so that you are sure that your distal edge and the proximal edge, specifically so, of the BVS has been deployed very well. So this is the post on RCA. I put a 2.75 29 through the guideliner and 3 into 32 outside the guideliner, taking a JL, AL 7 French to guide it as deep as possible. Now you see the area of 4.89 distally, 5.12, 7.04, 7.28, 7.15 and 6.22. It's a huge vessel, and you can see that the final outcome is excellent, and this is how it looks like. So when you have a very large RCA at the end of the day and you have to engage and take a shot, try and avoid saline OCT at that stage. But to be with what I do in such circumstances is that I make a mixture of 30% contrast and 70% saline and then take a shot. Two advantages. One, I can see the vessel very clearly where I have created a distal perforation or whether it's a slow flow or no flow or a thrombus. None of these can be obtained by doing a saline OCT. So this is the last shot which I showed you is a 30-70, 30% contrast, 70% with saline, and then we got a good result. So eventually we got an excellent result with the two overlapping scaffolds, and this is the area where we had actually overlapped. Okay. Now we come to the concept of blended PCI. The same patient on the same side, on the same day, we found that there is an LAD D1 bifurcation with a D1 which is almost as prominent as an LAD. You can see that the D1 is flowing very well. LAD is a big vessel, definitely bigger than the D1, but you cannot ignore the D1 totally. So in this case, we decided that we'll wire both together. We did a pre-dilatation and we got the LAD flowing well. We got a stent into the LAD, which was well into the near till the ostium of the LAD, but not coming into the left main. Left main was not involved. So we placed it perfectly and then deployed the stent. So now in these cases, I wouldn't like to take a BVS because by chance I have to go in for a bifurcation stenting, then it's a contraindication. You don't do a bifurcation stenting as of now with BVS. Although it can be done, we can go through, we can perforate, we can go through the bifurcation, we can do at least a drug-eluting balloon and come out. Not recommended, not studied as of now. So I ended up just doing a normal drug-eluting stent, and that's how we finished this case. So to summarize, we have an acute MI, RCA. RCA has a long lesion, 57 millimeter lesion, treated with two BVS, overlapping BVS, and we got very good flows, and the OCT was imaged predominantly using saline, and we got very good results. On the left side, in the same sitting on the same day, we realized that it's a dual LAD kind of a situation. I didn't want to have the option of not occluding the D1 and not being able to stent it. So we went for a provisional stenting with a drug-eluting stent, and we got away with good results. Finally, invite you to the 8th annual conference of the HICC India, which will be on November 22nd, 23rd and 24th in Kochi.